I'm very happy to be able to present on this. It was an exciting project. I think there's a very good summary of it in the handout here, so I apologize in advance if some of that's repetitive, but I think I'll not speak to every bullet on the slide and try to just give you a sense of the scope of it, what we talked about, but spend a little bit more time on what I felt some of the issues were that came up that I learned from and what some of the learnings are. So let's see if I can handle this. Well, starting right off, if you look at this, the time frame of this was really a two-part engagement that started in 2009, went into 2010. The only things that I'd like to say about this slide really are the timelines on the second part of the consultation were tight. That's very common in this kind of thing, but it did affect some things like logistics that I'll talk about later. And I want to be clear who the client was. The client on this was a stakeholder advisory group that had stakeholders representing a broad spectrum of health stakeholders and patients and the public and unions and others that was chaired by an elected official, Fred Horn, who was then the Associate Minister of Seniors and Community Services, is now the Minister of Health. And the Department of Health and Wellness, as it was called at the time, was a resource to us, a tremendous resource in terms of content, but our client was actually an advisory group, just for some perspective there. On this, the goals are there, again, separate from the bullets. What I'd like to say about this for some clarity is that what we were doing in this process was testing some ideas and getting input into some concepts that would form what I would call the bone structure of a framework for new health legislation. It was not looking for consensus, and it was not decision-making. It was to test ideas and gather a very broad range of input on that. So it was input into shaping recommendations. It wasn't making the recommendations. It was the advisory group that did that. And the other thing I would point out is that the topic, what we had to talk to people about, was legislation. Well, that's pretty dry, and that's very elevated type of discussion. So one of the things we had to do was make that meaningful to people around their health and health in their lives. And we'll talk maybe a little bit about that later. In terms of the strategies that we adopted, the stakeholders, the advisory group, and other stakeholders actually participated in designing the process for the consultation. There were almost three parts to it. There was the health stakeholder kind of pillar of consultation. AHS had responsibility. There's 90,000 employees of the health sector there for conducting a framework discussion that matched this within their own system, and there were the public processes. There were multiple vehicles for engagement. I'll show a slide on that in a second. And the framework, for a number of reasons, given the fact we were talking about health and what it means in people's lives, as well as the legislation, we used both very open-ended and some focused questions throughout all the vehicles. And we actually bookended all conversations with open-ended questions. It was a clear strategic decision to do that. One of our real challenges was given the timing of this. We really went out, and the flow of conversation we got was just a drink from a fire hose. We got far beyond what we were out there talking about, and what we did was welcome that, and we took it all, but we had a fair amount of sorting to do, and what we actually did in the report was report on the topics that were part of the project, but provided what I call an outlier report saying, you would also be interested in hearing this is what else we heard. We provided open access to everything we heard, all the what we heard summaries, the results of the surveys. That was all posted online as we were going. And we made it very clear that the final report recommendations, that was the advisory group's report and its recommendations, had to have a clear thread in the report back to what we heard, because what we heard during the consultation affected very much virtually every component of the framework. I'm just going to put this up and again not go through it in much detail, but as I said, for the public, we had a website that had a discussion guide and an online survey tool. We had discussion kits, so people could download kits if they wanted to get a group together, have a kitchen table discussion. We had public meetings. I really shouldn't even have the word meetings up there. They weren't really that. We made a clear decision not to go with town halls, given the topic and the depth of the discussion. It was something closer to the 21st century type of discussion without all the electronic feedback mechanisms. The facilitators were the feedback mechanisms. But we had small discussion groups with an open and closing plenary. The closing plenary was very clear about what we'd heard as key themes across all the rooms, using the language of the participants. We used a bit of social media, but not much. This isn't a conversation you can have in 140 characters, but we did flip out to people kind of what was happening as we went in these brief little burps, but that wasn't one that really fit the toolbox that much. AHS had focus groups. They had some web-based forums. And the CHCs, which are actually the health advisory councils, not the CHCs, we came into this process, and I'll speak about that as an issue in a minute around the timing, just as these health advisory councils were being set up. And I mean just. I think their first meeting as health advisory councils, we showed up on the agenda to talk about a consultation we needed their cooperation and collaboration on. So we attended that briefing with them. We got their input into what we were looking at discussing, and then we worked together with them for 12 of our sessions. And I have public meetings in the public website and online here as well, because we did find in the health sector, if you're an employee of the health sector or a health stakeholder, you did use the public mechanisms as well. They were online in the survey, and they were attending at our public meetings. For health stakeholders, we had a broad number of them give individual presentations to the advisory group. We accepted written submissions. People put a tremendous amount of care and attention into their written submissions. We had a forum with health stakeholders that showed the results of what we'd heard from the public and presented it to them for further discussion. And again, they participated in the public meetings and the public tools that were online. Just quickly, some numbers. They speak for themselves. I won't go through all of those. I do want to talk a little bit about the 23 communities at 2 per day. That creates some logistical issues. It was necessary. Once you get into these, there's a request to do more and more communities. We started out at 12. We did 23. By the end of it, in the discussions alone, we had over 1,200 participants. And we kept our discussion group size between 10 and 14, so that's roughly well over 100 separate discussions that took place during that time. The scope of the conversation, we asked about input to draft health system principles. People changed those considerably. We asked what they thought about the concept of a health charter. We asked about ongoing public engagement, how they would like to be engaged, because part of this legislation was going to look at a requirement for that sustainability piece around engagement. We asked them what they thought about the role of a health advocate. That started out as a patient advocate early in the discussion, became more of a health advocate as a result of these conversations. What were the role, the implications? How did they want to ensure more transparency and accountability? And what other priorities did they see for government action? This was one of those open-ended, what really matters to you questions that were quite necessary. Let me just speak for a minute, too, on the issues. There's always issues when you go out to do a consultation in a very visible way with the public. I just want to touch on these quickly. Timing. We were out in the field having these discussions not that long after a single health system was created by the government of Alberta. People had not yet had a formalized platform to express any feelings, issues, concerns they might have about that. We were out talking about legislation, and what people wanted to talk about was care for their parents and loss of a feeling of local connection to the health authority, which had a regional profile ahead of that. So we had to manage that both in the process, but much more just in the way we managed the discussions. So we heard an awful lot of issues related to health delivery, about food, about changes to seniors' living options, those types of things. So the timing affected the tone and the strategy and the skill requirement of the facilitators. It affected a great deal of things in this consultation. The other thing that affected things was the level and the complexity, the focus of the discussion. People needed some knowledge base to get into this discussion. So we used some PowerPoint, we used some of the web tools, we had a Q&A up front to make sure people understood what we were talking about around a health charter, around an advocate. Then we got into the discussion. The other thing we had to do, as I said, was really start with open-ended questions. We started with two really simple ones. What do you think is working now in the health system for you? What isn't working now? And people needed to get that off their chest so we could move on and talk about the future, and we could move on and we could talk about what's being considered in the legislation. So we had to handle a fair amount of emotion. The other thing I would say was logistics, that we had two teams on the road every day. One would be in one community. We'd have the other one fly in ahead or drive in ahead or truck in ahead and have a room set up so we could move the whole team into the afternoon or evening one. Given people's times, we had to have one in the afternoon and one in the evening every day so that the people could be there given the times. Real diversity of locations. We'd show up, the local cow auction mart was the room we had. We make it work. We really needed skilled facilitators. And I'll say one other thing about this. Given the atmosphere in which we were conducting this discussion, people really needed the logistics to work. If they'd have shown up and they had to wait in line to get into the room, it would have been symbolic about the way things were around the issue. So we spent a fair amount of time on the logistics. What else would I say? Appropriate media role. The media followed us everywhere, particularly the big meetings in Edmonton and Calgary, and we had a number of them in both cities. What's an appropriate role when you're trying to have this kind of a discussion? They were present for the opening. They heard all of the setup and all of the briefing and the Q&A. They were back for the close in the plenary where they heard in very frank language what we'd heard across all the rooms, in the language that we heard it. But there was a lot of pressure for us to allow them into the discussion groups themselves, and that really affects the discussion. So we had to manage that. So that was an issue. And the range and influence of interest groups, they're critical because they represent a particular point of view. They should be part of the discussion. You don't pick them all up in the stakeholder piece. They will attend. There was just very many of them across a broad spectrum, and they affected a number of things that, they drove some to the website, so it would affect the survey results. You could see we asked, are you employed by the health sector? Are you a health professional? And you could really see some of them were driving to the surveys, which is fair enough, but it's just something you have to be aware of and manage. And I guess my final slide, I hope I haven't taken up more than my time. Some of the learnings in this, the power of direct contact on issues of high personal importance is critical. The word we heard over and over again out there was trust. We had a very skilled elected official with us who I think made them comfortable in speaking, and we heard over and over in every community, we really appreciate the fact that you came to hear us because we were really anxious to have this discussion about the health system. The advantages and limitations of different engagement tools, when and how they're used. I think other people will probably present on that. I really find process is one thing, but if you cannot adapt as you go, especially if you're on the road and you're doing a lot of these sessions, we had to adjust our opening, we had to adjust our pacing. Food came up so much as an issue. We had to have a way to take it out of the room early. So now today, Minister Horn went to a hospital, ate the food. He was able to say in every room, I've eaten the food. This is what I think. We could deal with the issue. So this adaptability to what we were hearing was critical. Language matters. Use the language people give you, not the language of we used the language we were getting from them through all of our closes in our plenary. And emotion can be a very positive propellant. I know in a lot of public policy discussions, people are trying to contain emotion. How do we avoid it or contain it or deflect it? we really found in allowing people to speak to it, it made the discussion we had to have about the health legislation even richer. And process matters, the tools you select matter, but I'll tell you the skills of the facilitators in those rooms was absolutely critical. And that's my presentation. Thank you.